All right, welcome back to the Private Parts of Wellness. I'm Jessica, I'm your host. I'm also a nurse practitioner, a menopause provider, and I am your guide through all things midlife and beyond. We talk about that stuff that you probably can't ask your best friend, and you might find yourself Googling at 3 a.m. Today's episode is going to be science based. I'm talking about cocoa, as in chocolate, GLP1s, as in weight loss, and magic mushrooms. I'm also going to be talking about menopause over 65. So if any of those things are interesting to you, stay with me. Hopefully you will learn things that you had no idea about. So let's start with GLP-1 because GLP-1s are all the hotness, all the rage. If you don't know what I'm talking about, a GLP-1, I'm talking about Ozempic. I'm talking about Wegovy and Zepbound and Mounjaro. What's the difference between all of those? Well, one is semaglutide, the other one is tirzepatide, and they're both GLP-1s. They act a little bit differently, but here's the interesting thing. You're going to start to see a lot of information about GLP-1s or a lot of talk about GLP-1s taking these weight loss drugs and for truly for insulin resistance, diabetic control, and how it applies to people in midlife. Because it's no secret that in midlife we gain weight. Some of us do. Cree Summers did not gain weight. Cree Summers got horny and lost a lot of weight, and bless her heart, I wish I had what she had. But anyway, because that ain't me. That ain't me. And so there's an interesting fact about taking GLP-1. In fact, specifically taking GLP-1 tirzepatide and HRT, hormone replacement therapy. So one of the things that you may or may not know, if you've been following me for a while, you will know that I like to get my information not just from the Menopause Society. I am a member, I am a certified menopause provider through the Menopause Society, but I also like to see what's happening in the world of menopause. And one of those places that I look to is the British Menopause Society. Why do I look at the British Menopause Society? Because they've done some pretty amazing work. They brought the whole concept of menopause and the workplace. So, how women are affected in the workplace, quitting jobs, just kind of sometimes crashing out, as the kids will say, in the job place around the age of 50. Really, when we're in this very, very vital time with lots of energy, focusing on the career, having the life experience behind us, having the job experience. Anyway, lot to be learned. And they came out with a tool from the British Menopause Society, and this was done 2025, called Use of Incretin-Based Therapies in Women Using Hormone Replacement Therapy. So I'm sorry if I said it wrong. Incretin therapies, based therapies refer to a class of medications used for the treatment of diabetes and obesity and mimic the action of incretins, gut hormones, that regulate insulin secretion, appetite, and satiety, amongst other functions. So what they're talking about here are GLP-1s. And so there's a whole conversation about how those people who have lost a lot of weight on Ozempic or on the semaglutide, tirzepatide are getting pregnant. And we're talking about fertile younger people in most cases, and maybe even some older people. The idea, I think that the general idea was that they were getting pregnant because they were losing weight. So they were getting healthier. But in reality, what they're finding is that GLP-1s can block I may not be saying this perfectly. Remember, I'm doing this kind of I'm just talking to you. This is not really happening because they lost weight and they're so healthy now. I think that's a part of it, but it's really happening because it stops the body from taking the progestin and the progesterone and having that function in the body. When we think about the birth control pill, especially the one that you can get, like the O pill that you can get in the drugstores in the United States for now, because who the fuck knows what's going to happen. That is a progestin only pill. So let me read this to you. So here's the thing. So this tool for clinicians will focus on semaglutide and tirzepatide, but the general principles apply broadly to products from these classes of incretin-based therapies. The idea is that when you are taking these medicines, common gastrointestinal side effects are that it's longer to empty the contents of the stomach. So you stay fuller longer. And what this says is, in a review of drug interactions based on pharmacological profiles described, Eli Lilly resulted in possible interactions from a kinetic motion pharmacology medicine, the kind of, that just means the action of the medicine perspective, tirzepatide might impact the absorption of progesterone, similar to combined oral contraceptives. The pharmacodynamic properties based on the mode of actions do not reveal a particular risk of pharmacodynamic interactions. However, it goes on. However, diabetes mellitus belongs to the condition. Okay, that's too much information for you. The point is that what they're saying here in this paper, you need to, and you're taking oral contraception, the pill, a progestin or progesterone in the sense of micronized progesterone that we take in HRT or MHT, menopause hormone therapy, hormone replacement therapy, you need to really be cautious about the progesterone and the tirzepatide because you may not be absorbing enough progesterone. And of course, when we are taking progesterone, we need to take progesterone if we have a uterus. So I hope I'm being clear. So while a lot of people are taking GLP1s to lose this middle age weight gain and this menopausal weight gain, if you're taking HRT, you may be experiencing other side effects. So the general guidance from the British Menopause Society is, number one, in women with obesity, there is an increased risk of endometrial hyperplasia, cancer, and death from endometrial cancer. Okay, that's a really rough statement. But what does that mean? Endometrial hyperplasia means thickening of the endometrium, thickening of the uterine walls. What we know is that if you have a uterus, period, if you have a uterus and you do not have enough progesterone to counter the estrogen, you can have thickening of the uterine walls. So how do you know if that's happening to you? You may have, if you're postmenopausal, you may have bleeding all of a sudden, you might have bleeding with sex. There are just different signs. Something is kind of off. You might also notice, it doesn't say this, but if you have the benefits of progesterone, you've been sleeping excellent with the progesterone, and then all of a sudden you're doing the night waking again, and your anxiety is off the hook, but you're losing weight. It could be that progesterone is not doing what it needs to do. Number two, sustained weight loss in women with obesity appears to reduce endometrial risk. Now, why would that matter? Of course, they're focusing on obesity here. And in the United States, a lot of people are using GLP1s to optimize, they're microdosing it. And that changes too, as far as how absorption works. Why would they say in one hand, obesity, right? Women with obesity, there is an increased risk of endometrial hyperplasia. And they don't mention GLP-1 here. They're saying that because what we know is that when our ovaries are not making enough estradiol, which is the most abundant, strongest form of estrogen, it's what's in the patch, it's what's in the pill when we're thinking about HRT. Just in general, we love estrogen. So we got to make it somehow. And the more fat we have on our bellies, the more adipose tissue, the more E1 is made. So a different type of estrogen is made. And when we're making more estrogen, right, it can create more thickening of the uterus. So that's why they're making that distinction and listen, if you're a menopause specialist and I'm getting something slightly wrong, let me know. Again, I love to learn. So if there are little things that I need to tweak, let me know. And then of course it says number 2, sustained weight loss in women with obesity appears to reduce endometrial risk. Yeah. So if you are not what they say in like the kind of functional medicine world, like estrogen dominant, and you kind of get a little more balanced, well, then your endometrial risk of thickening is lower. Number 3, in women with obesity/overweight with comorbidities of diabetes, transdermal route of estrogen is preferred, and this is also the case with concomitant use of incretin-based therapies, okay? Then they say basically GLP number 4. GLP-based therapies delay gastric emptying and therefore may reduce the absorption of any oral component of HRT. Okay, so they're saying, first of all, when you look at all of the studies around estrogen and HRT, and we're talking about, replacing or adding estrogen, however that makes sense for you as far as MHT, HRT, the kind of general thought is that topical application of estrogen is the safest route. Now, there's a slight change in the guidelines that says, look, if everything is good and the blood pressure is good and they don't have a history of DVT, meaning you are kind of on the, you're within the window of 10 years from your last period. So you're in the 10-year window, you're under 60, you don't have heart disease, you don't have high blood pressure, you've never had a blood clot, essentially no problems, like clean bill of health, everything is good, cholesterol is good, everything is like hot, tight, good, right? You can take an estradiol pill. But this is saying, but in most cases we want to do topical. That's the safest route for everyone. And when it comes to taking hormones and GLP-1, we have to remember that oral medication, we need to have more caution. Their end note recommendation is, if you're using a combined patch, like the combi patch, we really only have one combined patch, which is the combi patch that is estradiol and then a progestin. So it's not micronized progesterone in it. It's one of the progestins that is used typically in birth control. If you're using that combined patch, you're good. You're safe. Like your endometrium is being covered. There's enough progestin to oppose the estrogen that you're adding. Second line, if you are taking standard doses of GLP-1 and you've got an estradiol patch, you want to think about using the IUD. And we're talking about the Mirena. We're talking about using something that is an IUD that has progestin in it. And then the third thing is, if you cannot use an IUD, don't want to use an IUD, don't like the combined patch, their suggestion is that you increase the dose of progesterone at initiation for 4 weeks and maintain higher doses for 4 weeks after dose increments. What the hell does that mean? That means you're going to take more. So if you're already taking 100, you're going to up it. Not you're going to talk to your provider about this. But your provider, and you would talk to you about increasing maybe to 200 for the first 4 weeks as you start your GLP-1. So if you're starting at 2.5 milligrams, you would just up it to 200 for a month. Each time you go up in your dosage, you would then again make sure that you would increase. So what does that look like? That looks like you are at 2.5 milligrams for a whole month. At week number 5, you remain at 2.5, so then you go down to 100 milligrams. At week number 6, you stay at 100 milligrams because you're still at 2.5 of your GLP1. But then you're going to go up to 3 milligrams of your GLP1. So then for 4 weeks, you would then go up again from 100 to 200. You get the idea. I'm going to leave it at that. The other option is kind of the off-label option, which is something that I actually had to do, not for GLP-1 purposes, but when I started to take progesterone, micronized progesterone, it was making me so sleepy, I could not function. And that is to place the progesterone in the vagina. So what we know about that is when you do place a progesterone in the vagina, it kind of goes to where it needs to go and does what it needs to do, and you bypass the whole gut emptying. So that was the other option. They also say women who continue to have unscheduled bleeding despite modifying their progesterone intake while using GLP-1 therapies, or where there is concern about the clinical presentation, your bleeding has gotten worse, the pattern has changed, you should be assessed to exclude endometrial pathology. So we need to check you out. You need to go to your provider. If you're seeing somebody online, you need to find someone in real life who's going to check you out. And it says it may be prudent to consider investigation earlier than stated in national guidelines in high-risk women. And that says expert opinion. So anyway, I thought it was interesting as people are really into their GLP-1s, meaning the Ozempics, the tirzepatides, semaglutide, Wegovy, Mounjaro, Zepbound. I think those are all the names. There's another one, I don't remember what it's called. But if you know, kind of thing. But if you are taking one of those medications to lose weight, that you definitely need to talk to your provider about your HRT and make sure that your endometrium is protected and that there is a wonderful balance of estrogen and progesterone. Why is that? Let's get into this a little bit. Why is that? Because the guidelines as far as how long you can stay on HRT have changed. And I don't know if they've changed. I don't think it's a big change for a lot of people, but the point is that you don't necessarily ever have to go off. So it is a big change. It used to be that you would stay on it the smallest amount of HRT for the shortest amount of time. And now they're saying, nope. You can stay on HRT until it's over, until you don't want to be on it anymore, or until you leave this earth. That's really interesting news. I came across another article recently, and this one was from May of last year, and it was published in Menopause, which is the journal of menopause. And it is use of menopausal hormone therapy beyond age 65 and its effects on women's health outcomes, types, routes, and doses. So this research is a pretty huge piece of research. They analyzed prescriptions and medical encounter records so that they actually saw, they looked at prescriptions that were filled. This is really important in Medicare. And they looked at 10 million Medicare women from 2007 to 2020. They used this Cox regression to assess the effects of hormone therapies. Cox regression, I think that's kind of funny, but whatever. Estrogen alone, estrogen with progesterone or progestin, and the outcomes that they looked at were mortality, cancer, heart disease, and dementia. So I'm just going to tell you really quickly what they found. So this is about women who are continuing HRT after the age of 65. So estrogen only therapies were linked to a significant reduction. So this means that these were women who are on estrogen only for a long period of time, and they carried on after the age of 65. So they saw that estrogen only all-cause mortality decreased by 19%. Less people died. Breast cancer, I mean, they eventually died. Breast, lung, and colorectal cancers decreased 16% for breast, 13% for lung, and colorectal, meaning colon, rectal cancer, 12. Congestive heart failure down by 5%, venous thromboembolism, like blood clots, by 3, AFib by 4, and MI, heart attack, by 11, and dementia 2. Now with combination progestin, not micronized progesterone, but progestin and estrogen, increase of breast cancer went up, but this was lower with low dose. And this is also lower with transdermal or vaginal. So it kind of changed. Reduction in each endometrial cancer was down by 45%, ovarian cancer 21, ischemic heart disease by 5, CHF by 5, and VTE, which is that venous, like a blood clot, by 5. Estrogen and oral progesterone showed mainly a benefit in congestive heart failure. Now, I have told you, or I don't know if we're just meeting for the first time, but I've talked about my kind of journey and why I chose to take HRT myself. And it was because my family had a significant cardiac history. And so I was like, oh, I'm going to get on this shit. I was also having hot flashes and night sweats and rage, but my choice was longevity. So lower doses and non-oral routes like vaginal or transdermal had better outcomes, and estradiol, which is body identical. We're not talking about bioidentical, right? That's a marketing term. I'm talking about body identical, meaning that the chemical structure mimics what we were making or do make. Estradiol performed better than conjugated equine estrogen, which was the whole problem with the studies from way back when. Now, one of the things that the paper also does address, not as robustly, is this idea of women who are naive to hormones. The rule again is that you have a 10-year window. So it's been 10 years since less than 10 years since your last period, and you must be under 60. That's the ideal candidate. There are other factors as well, but that's kind of the ideal candidate. It does address those people who are over 65, and it does suggest that it's not an absolute no for those women, which is pretty exciting. It suggests that if you are thinking of very low dose, non-oral route after 65, the risks may be lower and you may have several health benefits. So it's a risk benefit discussion that you would have. I have to say, as a provider, which I am, as a provider, I love working with older people. There was a period in my life where I was working a lot with people over 60, and I was actually working with them around sexuality, sex and sexuality, and having these groups and discussions around having a full sexual life. And the conversation is really not, there gets to be a point where the conversation isn't so much on this concept of longevity. It is about how to live. It's about quality of life and the robustness. Is that a word? Robustness of time that we have left in these vessels and in these vehicles. And I have to say, like, dealing with, as a person who's in between that age, I've got a young kid at home. I've got older adolescents at home. They like to pretend they're grown. They ain't grown. And then I have an elderly parent. These elderly women are struggling. They're really struggling. And I don't know if at a certain point, a little estrogen would more than it would hurt, which is probably very controversial. I was a hospice nurse for a while and I loved it. And I think that, like sex, we need to also consider and think about our death and how we want to leave the earth. Which leads me to my next topic, magic mushrooms, psilocybin. So I'm talking about a lot of shit. There was an article put out June 19th, 2025 called One Psilocybin Dose Eases Cancer Depression Over Long Term. So in this small study, this was published by Medscape. Medscape is part of WebMD. So this paper talked about a clinical trial that's in phase 2. And what it says is a single dose of psilocybin, we're talking about like magic mushrooms, combined with psychological support can provide lasting relief from depression and anxiety in patients with cancer. So here we're talking about quality of life. Like, how do we want to spend the rest of our days? So in a phase 2 trial, clinical trial, this was written by Megan Brooks, more than half of the patients reported sustained reduction in depression and nearly half reported significant reduction in anxiety 2 years after treatment. Argawal and colleagues explored the safety and feasibility and efficacy of psilocybin-assisted group therapy in 30 patients. So it's a small group. Mean age 58 years, 70% women, 80% white individuals with major depressive disorder and a curable or non-curable cancer. Participants received one-on-one and group therapy sessions and received a single 25 milligram psilocybin dose. Earlier results from the trial showed that at 8 weeks post-treatment, 25 of the 30 patients, that's 80%, had lasting response to psilocybin, and half demonstrated full remission of depression symptoms by week 1, which lasted for at least 8 weeks. The latest findings explore depression after 2 years. 28 patients available for follow-up. 2 patients died. And it says at 2 years, 15 patients, 54% demonstrated ongoing benefits and significant 15-point reduction in Montgomery-Åsberg depression rating scale scores, 14 of which had full remission of depressive symptoms. Psilocybin also helped relieve anxiety. At 2 months, 22 patients, 79%, had a significant 17-point reduction. Blah, blah, blah. Okay, I'm going to leave you with we're going to talk about one more thing, okay? But science suggests that one-time use of these agents can allow... So why does this work? So we're talking about magic mushrooms. They are legal in certain parts of the United States, like the West Coast, Northwest Coast. They are not legal in other places, but people do them. So stop playing. If you're interested in learning more about psychedelics, there's that How to Change Your Mind. There's the Fungi movie. There's lots of information right now about psychedelic medicine. But what this writer says is the science suggests, actually, this is a quote from one of the researchers. The science suggests that one-time use of these agents can allow for a sudden increase in neural plasticity, allowing for new neuronal connections to form where they wouldn't in other conditions, and for older connections to break down and restructure, Wilson explains. If our brains are etched with the stories of our lives, if our behaviors deepen and reinforce those psychological ruts, psychoplastogens like psilocybin may loosen the soil, so to speak. So I bring this to your attention just because I think it's all connected. We started with GLP1s. People use GLP1s. Yeah, definitely. They use them for diabetes, obesity, insulin resistance, and more they're finding also connections with the way that the brain works. There's the brain-gut connection. We know that the brain and the gut are connected when it comes to depression, feelings, mood. I wanted to talk about aging and how, well, from this whole GLP-1 the conversation and how your HRT may be affected if you are using GLP-1, things to look out for, but lead that into aging and quality of life issues and who's allowed to start or to continue their HRT, to psilocybin and how do we understand quality of life. Anyway, I'm going to leave you with one more scientific paper, which is from 2022, and this is from the American Journal of Clinical Nutrition. It's a randomized control trial, which is usually some pretty excellent, a pretty good study. This study was a 2-factor trial of cocoa extract supplementation and multivitamins for preservation of cardiovascular disease and cancer among 20 the women were over 65 again, and the men were over 60. They gave them cocoa extract supplements. So it had 500 milligrams of flavonoids and 80 milligrams of epicatechin. I might say that wrong. Or they received the placebo. So the conclusion was that cocoa extract supplementation did not significantly reduce total cardiovascular events, meaning it didn't stop big cardiovascular events, but it did reduce deaths. Sorry. So it didn't stop stroke. It didn't help with heart rate. These were the endpoints, heart attack, but it did seem to reduce cardiovascular deaths by 27%. And it says potential reductions in total cardiovascular events were supported in pre-protocol analysis. Additional research, this is what we say in all things, is warranted to clarify whether cocoa extract may reduce clinical cardiovascular events. Anyway, so pretty interesting. This said that a little chocolate, some cocoa, can help your heart. Well, we already know that cocoa can also make you feel like you're in love. It also can relax you, which seems strange because when we think about hot chocolate, we think about caffeine. But anyway, here's the takeaway. If you are taking a GLP-1 and you are on HRT or you are on any form of oral contraception, please talk to your provider about adjustments that may be necessary. Number 2, if you are approaching 65, if you know someone who's older than 65, and 65 is pretty young, but you know what I'm saying, I want you to consider not necessarily longevity. Definitely if you're 65, consider longevity. But if you have people in your life, if you're 65 and you're looking at your elderly parent, right, or aunt or whomever, I want you to consider having a conversation about how they want to live out the rest of their lives. So whether it's 10 years, 20 years, at a certain point in midlife, 20 years seems short. It seems really short. So how do they want to live out? How do they want the quality of their remaining time to be played out? And what are their fears? What are their anxieties? And what would they be willing to explore? And perhaps they're like, yeah, I did mushrooms in the 60s. I would do that shit again. Then great. I mean, go to the appropriate place. And I'm not telling you to do anything illegal. I'm not suggesting you do anything illegal. I'm just suggesting that there's information out there and it may be helpful. And if all else fails, have some chocolate. Have the fucking chocolate. Have the chocolate if you're on GLP-1. Have the fucking chocolate if you are heartsick. Have the fucking chocolate if you're sad and lonely. Have the chocolate if you feel out of control because the world is out of control. Have the chocolate because it's good for you. All right. That's it. I hope you got something from it. Like always, listen, I want to know how this was for you. Tell me what you want to talk about. I can keep talking about this shit I find because I'm always trying to learn more and more. If I miss something, let me know. If you want to leave me a message, you can leave me a message. I'll put the link in the show notes. If you would leave me a review, rate it, give me some feedback, give me some comments. Oh, I would love, 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 love that. If you would share, that would be great too. But until next time, I am going to do another episode actually on body image, and that hopefully I will get that out in a week or so. But thanks. This is what's been on my mind, what's been on my heart. I hope it's helpful. I have a feeling it's fucking helpful for someone, okay? All right, hang in there. All right, have the chocolate. Think of me. Thanks for listening. Bye.